Medicolegal risk in ectopic pregnancy, evidence-based points every gynecologist must know. Now, as said by ILA, ectopic pregnancy is a life-threatening obstetric emergency. It needs prompt diagnosis and treatment, and it is associated with the increased maternal morbidity and mortality, but with the significant impact on the fertility also. Though the mortality is reduced, as said by her, because of the prompt recognition and timely intervention made available by the sonography and the blood test of the beta HCG, but still it accounts for almost 50% of the death related to the ectopic pregnancy, more so in the rural areas where these facilities are not available. And the incidence has been already told by Dr. Ila that it is increasing, and nowadays there is a steep rise in the incidence of the cesarean scar pregnancy also. So there are 95% of the ectopic pregnancy are tubal in origin, and I'll be discussing more in detail about tubal pregnancy. And the rarest one are the after the cesarean section pregnancy. The rarest are the cervical pregnancy, the abdominal, ovarian, and the pregnancy of the unknown location. Usually, all the gynecologists are managing the ectopic pregnancy very well, but the legal implication can arise when the healthcare provider falls below the action standard of the care given to the patient, resulting into the harm, and there is a breach of duty. The legal implication also involves around the potential for the civil liability, the professional misconduct and medical negligence, and criminal charges can also be put under section 106 BNS and BNS section 125. Ectopic pregnancy.
Yes, Dr. Raj.
The various key medical legal issues related to the ectopic pregnancy are the diagnostic error, the treatment related issues, there is lack of proper counseling, informed consent and documentation, when the complication and the adverse outcome results, and in case of the emergency is not managed and referral is not done in time, it can result into the loss of the fertility. And the last one, the legal application can be due to the medical legal case, and when the confidentiality, especially in the minors, are warranted. Now, everyone knows that the high index of the suspicion of the ectopic pregnancy to be diagnosed are by the history, the clinical examination, the beta HCG level, and the transvaginal sonography. And the delay in the diagnosis, which triggers the litigation, is the major reason. And it happens when there is a failure to diagnose, the ectopic pregnancy is missed, and there is a wrong diagnosis, or the tests are not interpreted properly. Failure to consider ectopic in early pregnancy in presence of the bleeding or pain is the first when one can miss the diagnosis, especially when it happens. There are the early thickened endometrium and with the presence of the corpus luteum on the ultrasound, and when the serum beta HCG is not advised. Only doing the urine pregnancy test and coming it as positive is not enough, because it confirms only the pregnancy, but it doesn't rule out the ectopic pregnancy. Hence, quantitative beta HCG is a must if one is suspecting the ectopic pregnancy. And it is so common that when the patients are wrongly diagnosed, and it becomes very dangerous, because initially when the patient is presenting with a slight discomfort or slight spotting, they can be misdiagnosed as the threatened abortion and are treated for that, and or as the PID. So it becomes very important to ask for the detailed history. The history plays a major role, especially about the past history of any infertility related surgery done in the past, or there is a previous history of the ectopic pregnancy, there is any history of the ART pregnancy, especially when there are ovulation induction or IUI or the IVF conception. Any past history of tuberculosis, any PID infection treated. And again, it is very important to ask for the emergency pill intake history. Especially nowadays, it's so common that the young adolescent girls and even in the reproductive females, whether they are sexually, when they are sexually active, married or unmarried, they take the emergency pill and it predisposes for the ectopic pregnancy. So it becomes very important to ask in detail about all the history. And we know that the early warning sign of the ectopic pregnancy, no one can miss it: abdominal pain, amenorrhea, and the spotting, along with the beta HCG positive. Now it becomes a breach of the duty and it comes into the medical neglect when any patient with the early pregnancy reports with the pain, and any they are just discharged without advice or getting it done transvaginal sonography to confirm pregnancy or rule out pregnancy, and not even advising any follow up plan to get repeated beta HCG level or the vaginal sonography. So we can say that a single beta HCG is never enough. It is, everyone knows that either it is rising not to the extent of the more than 65% or doubling in 48 hours, or there is a falling titer or the plateau, which matters a lot in the diagnosis of the ectopic pregnancy. And it becomes a red flag sign when the beta HCG is more than 1500 international unit per liter, and on ultrasound there is no intrauterine gestational cell. This I have already told. So we can say that a normal ultrasound report doesn't rule out ectopic pregnancy unless it confirms a intrauterine gestational set. But while doing the ultrasound, and especially with the history of the ART conceptions or the IVF conception, one has to be kept in mind the possibility of the heterotopic pregnancy with a live fetus in the live intrauterine pregnancy. And in these cases, if the patient complains of persisting pain, so a vigilance is required to exclude the heterotopic pregnancy in these cases. Otherwise, it becomes reason for the litigation, and the patient can end up into the in the hemodynamically instability condition due to the rupture. And these patients should always be told about the warning sign of the tubal rupture, that is the acute pain, abdomen, vomiting, blackout, fainting attack, and these patients should be warned to report immediately whenever there is such possibility occurs. So again, it says the same thing, ultrasound picture of adnexal, finding the adnexal mass along with the absence of the intrauterine gestational sac and presence of the ecogenic fluid in the pelvis and beta HCG titer proves the ectopic until it is ruled out. So both the TVS and the serial ultrasound, serial HCG blood test are complementary, and it should be done always to rule out the pregnancy by keeping regular follow-up. It is advisable and always preferred that every gynecologist should master in the transvaginal scale, and we should not depend on the radiologist alone. But those like me, we are not without them. Either we present personally during the ultrasound, and then we should be discussing to rule out the ectopic pregnancy by the radio or by the sonologist. And it is so true that what you have in your mind, your eyes sees that only. The various treatment pitfalls which are important to cause a litigation are either delaying the treatment or you do the improper treatment. You don't consider the various risk factor. There is a counseling and the consent is not proper. And when one fails to act on worsening symptoms and ignoring the symptoms of rupture, and even if you have diagnosed and you have treated, but the monitoring is also improper and the follow-up is not done properly till the beta HCG is negative. And it's very important that the compliance should be maintained. And whenever there is a complication and the adverse outcome, then it becomes the legal battle to be started, and one is held liable and the case can be sued. The other various scenarios in which the patient, which are commonly seen in the clinical practice, that when a patient comes in emergency and without going in detail history and clinical examination, the eliciting the cervical excitement, tenderness, and without getting all the proper investigation by the sonography and the beta HCG, one sends the patient back with only with the painkillers and without telling the warning sign and the red flag sign and explaining to report immediately and be under the regular follow-up. It becomes a not only dangerous, but it is becomes a prone for the litigation also. The counseling, general counseling, whenever you have a case of the ectopic pregnancy, should be done in detail. All the various treatment options, whether it is expectant or the surgical or the medical, it has to be individualized and on the clinical stability of the patient, the advantage and disadvantage of all the methods, medical versus the surgical, whether it is the salpingectomy or the salpingostomy. The patient has to be told about the follow-up compliance, which is very important, and risk of the rupture, the future fertility and the recurrence rate, and accessibility to the emergency service whenever the red flag sign occurs. So if one fails to explain the risk to the patient and the attendant both, then it can be interpreted as a breach of duty and it is counted as a medical negligence. In case of the, whenever one is suspecting or the ectopic pregnancy is confirmed, recording of the vitals hourly is very important. They are not only as a defensive in the court, but they shows your standard of care also. In the surgical management, the procedure specific consent counseling and detailed informed consent regarding the various procedure, detail about the procedure, whether it will be done laparoscopically or laparotomy, associated risk factor, the complication, the alternative, and there should be a shared decision by the patient also. One should be, while going for the surgery, one has to be very well versed about the proper instrumentation availability. Whenever needed, one should not hesitate in doing the laparotomy, and retrieval of the specimen should be done properly, and histopathology has to be sent always. And if you are doing a conservative surgery, then a follow-up is must. A repeat serum beta HCG at 1 week interval should always be done, and it should be told about the risk of persistent ectopic pregnancy, need of the second medical treatment or the second surgery should always be explained to the patient. Laparotomy should be done within an hour, because the time lost is the life lost. And surgical intervention is life-saving, even in the case of the methotrexate criteria are not met, and one should not delay in doing the surgery. And whenever we are giving the medical treatment, again as method-specific counseling and documenting all the detailed counseling regarding the dose, the selective criteria, the contraindications, and the side effect and the contraindication, especially the liver and renal disease, the breastfeeding, and also the peptic ulcer. It should not be given, and the serial repeated beta HCG level should be also told. Also told about the persistent ectopic pregnancy, where one can need a second dose, or if needed, surgical intervention may be needed. All has to be planned and properly explained and to be documented. It becomes a major medical legal risk whenever the methotrexate is given without confirming the ectopic. And this is just to enumerate the selection criteria. The patient has to be stable, hemodynamically stable. The level of the beta HCG should be less than 5,000. There should not be any intrauterine pregnancy on ultrasound compliance, and the pregnancy should be unruptured. And there should be the adnexal mass size should be less than 35 and no cardiac activity should be present. But though there are few cases where in presence of the cardiac activity and the size more than 35, the doctor has tried and it has ended into a successful end of the ectopic pregnancy. It is contraindicated, everyone knows, in unstable vitals, hemoperitoneum, or the ruptured tube. The expectant treatment, which should be offered only when the patient is clinically stable with no pain, no hemoperitoneum, and ectopic pregnancy size should be less than 30 mm, and beta HCG level should be less than 1500. But when I was reading, it was surprised to me that the success rate of the expected treatment is when the pre-treatment beta HCG level ratio at 48 hours and 0 hours is less than 0.8. I don't know if anyone has experience about it or not. So now it comes to the legal protections. And as I already emphasized, legal protection is only when one is following the protocols and according to the standard of the care given to the patient and to the various guidelines by the various organizations. And whatever you do, it has to be documented very well. So, and they will be the mandatory as a legal protection. Using a standard ectopic pregnancy checklist is a very good defensive in the level of the care as per your institutional protocol, and it will include all the right from the history, the clinical acumen, the various diagnostic tests you have offered, and whatever the line of the counseling and treatment documentation and plan of your treatment, including the patient's communication and to its relatives, all has to be documented also. So this will be not only the safeguard for litigation, and it will also provide the standard of care given by the treating doctor. So even in the emergency surgery, you should always document the informed consent, where you should mention the risk of rupture and the need of the blood transfusion. These are the saving God, and a breach of the standard care is taken when the surgery is delayed, or you are having a referral to a higher center is also delayed whenever the surgery is needed. So again, I repeat, it is the documentation and documentation and documentation in detail, which writing all very well about your follow-up plan, and becomes a good defense in the eye of the court. And a good defense, as it is always said, is a good by the good documentation. A poor documentation will be a causing a poor defense. There are the few special situations where the legal consideration in ectopic has to be considered. And these are whenever the ectopic pregnancy occurs in cases of the IUD or post-sterilization. Though none of the method gives 100% prevention or guarantee for the prevention of the pregnancy, but if they occur, they can cause the litigation, and the litigation can be issued in cases when there are the presence of the bilateral ectopic pregnancy, and which do happen in cases of the previous history of ectopic pregnancy or the surgery related to the infertility has been done. And it is also legal consideration, and the confidentiality has to be considered, especially when the ectopic pregnancy occurs in the minor, which is not so uncommon nowadays. And whenever an emergency, a patient is brought in shock, how to deal the patient, whose consent has to be taken, whether the consent is required or not, all has its own legal consideration, and one has to inform the medical superintendent and take to their HOD also. And it's always advisable to take, in cases of the emergency shock condition of the patient, where patient is unable to give the consent, to take an opinion by a senior another consultant. There are so many cases in the court, and the court which will be highlighted and dealt by in detail by the next speaker, Dr. Sonal. But I'll be just mentioning a few real case scenario which we have come across. In one case, there was in case of the emergency, the patient has reported in night, and she was taken up for the laparoscopic treatment, management of the ectopic pregnancy. And there was the unavailability of the 10 mm suction cannula, and due to the lot of the blood in the peritoneal cavity, one has to subject to the laparotomy. Loss of the specimen during retrieval is also possible, and one has to be very careful. Now, this was the case of the pregnancy of unknown location, though on ultrasound and by the beta HCG, it was diagnosed as the ectopic pregnancy. But the size of the ectopic pregnancy was very small, that is less than 15 mm. And because of the persistent pain, the patient was advised admission, and we thought the pain is not so much, and we were monitoring the vitals. But when the repeat ultrasound was done, there was increase in the little bit size from the 15 to 18 mm, and the fluid in the pelvis was little increased. So explaining and taking the informed consent properly, we may not able to visualize the ectopic pregnancy in the on laparoscopy. So and when we had done the laparoscopy, there was no ectopic anywhere, and the patient was just, we did only a diagnostic laparoscopic evaluation, and the patient was followed up with the beta HCG, which spontaneously regressed without any methotrexate. And after 2 months, she again got an intrauterine live pregnancy, which is going on. So the court view delay in the diagnosis or the delay in the transfer as a gross negligence, and the patient and the doctor can be held liable for the medical negligence. And whenever the death occurs in pregnancy, which is preventable always in the current scenario, but it always goes against the doctor. And one can be convicted when one fails to keep the blood ready, or the ICU backup is not there during the surgery. In recent judgment, non-specialist handling without timely referral has been called as taken as a reckless endangerment. And so to mitigation of the medical legal risk can be done when one suspects it early, confirms it promptly, and act decisively, follow the standard clinical guidelines for diagnosis and management, keep clear, accurate documentation of all the decision and the patient communication, ensure the informed consent with the risk benefit alternative, and also when if they don't undergo the treatment, the timely referral if needed, and expert opinion in complex cases. So the finally the closing message for all the gynecologists: every topic should be taken as a potential time bomb. Early suspicion, timely action, and precise documentation. Again, the documentation is the only shield against litigation and death. And thank you so much for the patient here.